I would like to address several topics that are specific to pathology in the hand. Skip hole injuries with tears of the ulnar collateral ligament of the thumb and its complication, the Stenner lesion. Injuries to the pulley system seen in rock climbing individuals. I will touch briefly on the Decussation syndrome, and then I will spend some time talking about compression of the nerves in the Ganglion canal and several examples of soft tissue masses which are specific to the hand pathology. At the end, I will touch briefly on the issue of selecting the best imaging modality, CT versus MRI, when specific clinical needs arise. The Stenner lesion is a very important diagnosis to be made for the clinician's point of view. We are talking here about an injury to the medial collateral ligament of the first metacarpophalangeal joint. In the past, this has been called the gamekeeper's thumb, but these days it is most frequently seen in skip hauling injuries. It is produced by a forceful abduction of the thumb, which produces a tear of the ulnar collateral ligament. It is also possible that the bone gives and we have an avulsion of a small flake of bone at the base of the proximal phalanx, which is actually the attachment site of this ligament. In that case, you may have a plain film diagnosis indicating the nature of the soft tissue component. However, in most of the cases, we need MRI to diagnose this injury, and it is specifically necessary to answer one question: where is the end of the torn ligament? We are talking about the proximal segment which retracts, and if the moment of injury was extremely forceful, or if this lesion was neglected in the next few days after injury and the thumb continued to move, the torn ligament end may herniate and extend outside of its normal tissue planes and travel on the outside of the adductor aponeurosis. In that case, we are talking about the diagnosis of Stenner lesion. A Stenner lesion cannot heal spontaneously because the torn ligament is outside of its capsular and normal tissue planes, and in follow-up of these lesions, one can see a permanent instability of the first metacarpophalangeal joint. Therefore, it is upon us to diagnose that the injury to the medial collateral ligament is in fact a Stenner lesion, in which case immediate indication of surgical repair is established. This is a set of coronal views of the thumb, and it shows us the injury to the ulnar collateral ligament. You see a lump of fibrous tissue here that does not belong. It is better observed in here. You have the torn medial collateral ligament, and this is a lump of fibrous tissue which represents a retraction, balling up of the torn end of the proximal segment of the ulnar collateral ligament. It is outside of the adductor aponeurosis, and therefore, with an image like this, we establish the diagnosis of a Stenner lesion with surgical indication of repair. This is the axial image of the same patient. This is the adductor aponeurosis, and you see the torn end of the tendon outside on the external side of it, and therefore, this is typical of Stenner lesion. This is a good example to demonstrate to you that the coronal views of the thumb are totally different than the coronal views of the hand This would be the plane for coronal views of the hand through the metacarpal head, and this is the coronal plane for the thumb first MP joint. Usually it has been described as having an axial view at the two sesamoids, and any plane that goes exactly through these two structures is the true coronal view of the thumb, and in this way you can image the perpendicular direction of the torn ligament and have good images. Therefore, when you protocol a case for a thumb lesion, make sure that the technician performing the MRI understands that this is a different plane. It's essential. Otherwise, your images are not going to be in the proper plane for the ulnar collateral ligament. Rock climbing injuries are rare in certain parts of the country. However, New York City is populated by world travelers, so we occasionally see such abnormalities. It is interesting that up to 40% of the professional climbers have this lesion. Therefore, it's quite frequently that selected group of individuals. It may have an acute onset or be a progressive, gradual, insidious onset. It results from abnormal stress on the pulley system, and I'll show you a diagram to understand what that is. The third and the fourth fingers are most affected because they are the longest and they have the most drastic forces of pulling off those structures. This is a sagittal representation and shows you the flexor tendons traveling longitudinally, resting on the bone, but kept in close opposition to the bone by the existence of these fibrous tunnels. The A2 pulleys are like cuffs of fibrous tissue firmly attached to the palmar surface of the phalanges. The C pulleys, the cruciate pulleys, are closer to the joint. So when we have a very forceful flexion with tension in these things, the tendon of the flexor may slip out, tear these attachment of the fibrous tissue on the bone and create the injury. Okay. The characteristic of the A2 pulley tear is bowstringing of the proximal interphalangeal joint. It is specifically seen clinically and also in MRI if you could obtain the images in the forced flexion position. In other words, flexion with resistance to it. This patient didn't need that because he had a major pulley tear that was not only in the A2 system, but probably in the C pulley adjacent to the joint. And the abnormalities are quite evident. We are talking about the increased distance between the tendon and the bone. We are talking about fluid in this area, and this structure is the torn pulley, A2 pulley, that is retracted here and has fluid between it and the bone, as well as between it and the tendon that is at a distance. Look at the abnormal position of the structures. In the axial images, you can see the two normal fingers, one next to the other, with a very strong attachment. These are the pulleys. Do you see this very thin bracket-like structures? This is the pulley containing the tendon into the tunnel immediately adjacent to the bone surface. As opposed to this situation where we have the tear, the tendon is at a distance, and all this fibrous tissue represents a scar formed in this chronic tear. Another issue of abnormal motion between tendons is the decussation syndrome. This develops at the segment where the tendon of the third compartment, which is the extensor pollicis longus, crosses over the second extensor compartment, the two extensor carpi radialis, longus and brevis. When these two tendons move at different synchronicity, friction develops between them and a chronic synovitis appears. I'll show you the anatomical drawings of Netter, which beautifully describe the crossover of the tendons. This is the third compartment taking a lateral direction towards the thumb, crossing on top of the second compartment with the two conjoined tendons. In here, it's a lateral view showing the same thing, the oblique direction of the third extensor compartment tendon over the second. And this is a MRI representation of the decussation syndrome. What do we see? We see two adjacent sleeves, the second containing two, and the third riding on top of it. In here, you see a ghost of tendon. The pollicis longus tendon wasn't a happy one at this level. It had some intrinsic tears because of the abnormal stress on it and internal derangement of the tendon itself with some interstitial tears. This is the synovitis component that you can see very well here with only two compartments involved. Everything is normal except these two. This is the second. The third is already lateralized to it. We see the tendon that doesn't look normal. And in here, we are much more distally. These two have separated now. We have the second compartment with fluid inside. The third is lateral. The tendon appears more normal at this level. So it is this specific synovial irritation that has created fluid as a result of abnormal crossing over and different tensile forces on these two tendon compartments. Ganglion cysts are very common in the hand and wrist. However, occasionally you have a symptomatic patient that may benefit from MR imaging, as in the example that I'm going to show you now of ulnar nerve compression in a surgeon's hand. He had numbness and tingling on the ulnar two fingers of his right hand, which he needed very much to be in good shape. And we imaged him with MRI, and we found very interesting findings that explain totally his symptoms. He has a ganglion cyst that is biloculated and is sitting distal to the pisiform. This is triquetrum, this is hamate. This is the location of the ganglion cyst. And in these two adjacent coronal images, you see that this is intimately associated with the margin of the joint between the hamate and metacarpal bases. It's sitting right here, and this image shows very clearly the association between the ganglion cyst and the hook of the hamate and the pisiform. The axial image is the one that locks everything in between the imaging point of view and the symptoms. This is the ganglion cyst that you can see very well, biloculated, and one of its chambers extends anteriorly as far as the Guyon canal and touches on the ulnar nerve right here. You have the ulnar artery and two veins, and the nerve is right here, and that explains why this patient had manifestations of ulnar nerve compression. A quick surgical procedure of drainage and excision of some of the walls of the cyst has cured this patient. Another mass that is quite interesting in its MRI appearance is the Fibrolipoma of the median nerve. Occasionally, across your desk, when reading plain films, a strange case like this will appear. And this represents a dystrophic appearance of the bones, as well as hypertrophy of the segments of the hand that are innervated by the median nerve. It's probably one of the characteristic appearance of advanced and long-standing consequences of fibrolipomatosis of the median nerve. This is an axial image through the distal radius and ulna, and look at the size of the median nerve. It's enormous. It's almost half or two-thirds the head of the ulna. Moreover, it is separated in bundles containing fibrous element as well as fat. These are two axial images obtained with different sequences. This is a T1 that shows the fat inside and the fibrous elements. This is following gadolinium, and you see that some of those fibrotic components are actually hypervascular. This is a sagittal representation of the anatomy in this patient that shows you how long this abnormality is. The fibrolipomatosis is not a tumor, it's a dystrophic infiltration with fibrous tissue as well as fat. It's extensive in length as well as anteroposterior diameter. It is extending from the wrist area all the way to the palm. We are now at the chapter of strange soft tissue masses in the hand. Fibromatosis is one of the issues to be discussed, and their change and gradual progression histologically to fibrosarcomas. It's a busy slide, but I would like you to concentrate on two main issues. That this is an aggressive proliferation of fibroblasts that is quite common in the pediatric group. Up to 10% of masses in the hand seen in children fall into this category. The symptomatology is either tenderness, pain, or functional disturbances, sometimes protruding masses that could be detected clinically. We have to differentiate between superficial and deep fibromatosis. From the general pathology, you are familiar with fibromatosis coli. In the same group of abnormalities, the digital infantile fibromatosis falls in. In fact, it's a form of desmoid, if you want to call it, and be aware of the fact that you cannot establish always a firm histological diagnosis, and some of these masses can have a histological gradation towards fibrosarcoma. I'll show you an example. Again, the plain films are telling us that something is happening here. There is this defect in the phalanx in a young child. There is abnormal alignment at several joints, and these lumps of soft tissue protruding towards the outside. The MR images show this scalloping of the proximal phalanx with a very long, flat, soft tissue mass that has a component here around the MP joint, another one in here at the phalanx, and in the water-sensitive images, you see that it is composed of a brighter signal indicative that it has a higher water content. The axial images show us the almost hemicircular component of the mass wrapping around the bone, and in here at this level explains why you saw on the confirmed that pitted lucent defect represents an abnormality of the cortex which has been transgressed, and a piece of this fibrous tissue enters the bone marrow space. The most typical soft tissue mass in which we all have quite rewarding results in the imaging procedures is the Glomus tumor. It is characterized by sensitivity to cold and point pressure, to the extent that the clinical diagnosis is almost certain. Then why do we do MRI if we know what lesion exists in these patients? Because we need to determine its exact location and its size. It needs to be excised completely so there is no recurrence. It also needs to have very precise targeting of the tissues transgressed at surgery, because fingers where this lesion is located are very essential functional elements, and they are also of great concern of aesthetical results to patients. So I'll show you a Glomus tumor, which is the size of a half a grain of rice, located in its typical area. It's underneath the nail in the distal phalanx, dorsal side. It's extremely bright spontaneously, but you may help yourself with lesions that are less than 3 millimeter in size by injecting gadolinium and then obtaining all the images after gadolinium. And you will see this hypervascular, almost hemangioma-like small mass. In the axial images, we see the nail, and underneath it, we see the soft tissue, bright signal mass with a gentle scalloping of the cortical bone. With these two images, we may give the surgeon very precise plans of action, and he will do a very limited incision as portrayed here. The nail is open only where the tumor is. This hypervascular tissue would be excised in total, and there will be extremely pleasing aesthetic and functional results with no recurrence. I will touch briefly on the issue of the selection of the best imaging modalities for different clinical problems. Which shall we do, MR or CT? This is an often asked question. And I would begin by telling you that in many situations, these are complementary examinations rather than mutually exclusive. To portray such a situation, I'll give you an example of a patient that had an acute injury to the third metacarpal head with extreme pain and a large hematoma seen clinically. The radiographs were negative, and the CT was done in search of an occult fracture. We found it. Donor side is this surface where cortex is missing, and the piece that was detached is displaced at a great distance. We understand why the plane fins were negative, because looking this way, you don't see the defect and you don't see the fragment displaced. They are covered by the other bone structures. And looking this way, this cortical surface obscures the defect in here. Now we know there is an avulsion fracture, but the distance at which this small fragment has traveled indicates that there might be significant associated injuries to capsule and the collateral ligaments of this joint. These are reformatted images. Have a look at them. There is a subtle change in the density of this metacarpal head compared with its neighbors. This is the donor side. I'll come back to that later. And this is the MRI in almost identical coronal planes as the CT composite image I showed you. Surprising findings. There is a very abnormal signal in the entire head and part of the neck of this metacarpal in the T1 weighted images. Water-sensitive images show us a very edematous area in the soft tissues around the joint. Please observe the normal parenthesis-like of the healthy collateral ligament of this joint and contrasted with this one. This is torn and hanging loose here with a lot of edema and hemorrhage around it. Same here, this is the donor site where that fracture was detached. I'm going to present you the same slide as the one you just saw before, and look very carefully. Now that we know where the fracture line has intercepted the metacarpal head, you start seeing a very subtle lucency here that otherwise would not have been spontaneously recognized probably. Yes, it is there, but it's so subtle that you have a hard time making a positive recognition of it initially. Another point I want to make is this one, that as much as we are enthusiastic about MRI showing us all the soft tissue injuries, the capsule tear, the collateral ligament tear, the bone marrow edema, and the fracture inside the head of the metacarpal, we are still falling short of recognition of loose fragments of bone inside the joint or avulsed fragments. Look at the CT. It's the same slides I showed you. Turn around to be exactly positioned as these two MRI slices in the axial plane. This is the fragment. It jumps at you immediately. It's the only thing you see in the first fraction of a second. Where is it here? If you compare the normal side with the abnormal side, you see that there is an extra low signal structure here and here, and then you realize that this is suspicious. However, it's hard to recognize it spontaneously. This is a pair of CT and MR in the sagittal plane outlining the same idea. The MR is splendid for showing you the fracture through the head of the metacarpal, which is very subtle here. CT, however, it shows you this triangular splinter of bone that is displaced. Where is it in MR? Knowing where to look for it, you do find it. It is right here, but it will be a very subtle finding. So, clinicians often ask you, which one should I do, MRI or CT? Which is better for my patient? And the answer depends on what you search for. If you are strictly interested in cortical bone and loose fragments, CT is probably the best and simplest way to image it. However, if you are concerned about a variety of soft tissues, such as capsule, ligaments, tendons, the soft tissue edema and hemorrhage around an injured joint, you are better off with MRI. MRI, of course, is extremely sensitive to any chemical changes in the bone marrow, be it edema, hemorrhage, or tumor. So the answer is, you may want to do one, but often you may do both because you need them both, as I showed you in the previous case. Another topic that I would like to briefly touch on is the utility of multi-detector computerized tomography in obtaining exquisite details at peripheral angiography. We think that CT offers in the hand and wrist an advantage in portraying abnormalities that are placed specifically and exquisitely in the anatomical boundaries that is very useful for surgeons. This is the CT angiography of a 25-year-old man who had tingling, had coldness and pain in the fingers of his hand on the ulnar side. There was no abnormality seen on clinical examination. We performed the CT angiography, and this is a sagittal reconstructed image of that study, which shows the ulnar artery traveling through the wrist. It reaches the area of the hook of the hamate, where it becomes beaded, has dilatation, and then the distal portion shows poor flow. If we want to give the surgeons everything, every piece of information on a silver tray, we produce a three-dimensional view of the bone structures with the arteries in place, and will look like this. This is the hook of the hamate. This is the ulnar artery that is abnormal here, has a small aneurysm. And if we want to impress them with our technical abilities, we do rotation of these images, and this offers a better view of the abnormality from different vantage points. You see that the artery has an aneurysm in here. It's beaded, irregular. This is a traumatic aneurysm of the ulnar artery, and its expected classic location at the point where it can be compressed between a handle of a tool that one keeps in the hand and the hook of the hamate. Between a rock and the hard place, the artery is compressed chronically or acutely and develops a traumatic aneurysm. These three images show us with a good vintage pointer profile that shows a kink in the artery, shows the aneurysm, and also show the poor flow in the palmar arches, explaining why this patient had such symptoms. In conclusion, I would like to stress the fact that all imaging modalities are useful on their own worth. We have to have a baseline of plain films in certain abnormalities, like that hand of the fibromatosis, lipofibromatosis of the median nerve, but we also have to advance further with MRI and CT and select from the protocols available the best plan for imaging specific abnormalities so that we can help the surgeons to accomplish their goal, to treat properly, thoroughly their patients with beautiful follow-up results, as well as aesthetic considerations that in hand and wrist are a major point.